Good morning, everyone. Thank you for being here. It is Wednesday, January 15th. These are the first hearings, bill hearings for the Finance Committee. I apologize for being a few minutes late. Believe me, there's a lot going on this time of year, but I really appreciate everyone being here, and I appreciate your patience. We're not going to use the timer today because these are all departmental bills. So I would like to start with the first bill, Senate Bill 157. Who would like to come to the table? Senator Sarner. Oh, this is not a departmental bill. This first bill is not a departmental bill, but it is sponsor only. So, because we passed this bill last year unanimously. Thank you, Senator.
I thought I got promoted there. Well, thank you. This is quite a pleasure coming here. First bill of the session. So I promise I'll be out of here within an hour. Seriously.
I can promise you we'll be out of here within an hour.
It's a pleasure to be here. As you mentioned, well, first, I'm Senator Brian Simon, presenting Senate Bill 157. As you mentioned, this bill passed unanimously, no opposition. You can see the written testimony, gobs of testimony in support of it. Basically what it is a grant program for service animals in the Department of Disabilities. It's modeled after the service animal program in the Department of Veterans and Military Families, which is hugely successful and doing well there. I won't go into any more detail unless you want me to. Regarding the fiscal note, same thing I said as last year. This assumes that this program will be funded at the same level as the Veterans Program, which it's not. And it also allows for private donations, which we did on the Veterans Program. We went out and raised money the first year to get it started. The other news I have is we have a crossfire this year, so it won't hopefully run into the time deadline. And we've already discussed having fundraisers for this already. And then the operating expenses around $8,000 a year, and I do agree with that. The other main difference is we got another co-sponsor on this bill, the chairman of B&T. He's very excited about this bill as well. So I could go into more detail, but with that, I would just ask for your favorable consideration.
I think that was a very smart co-sponsor that you got, Senator. Do you have any questions for Senator Simon for this bill that we passed unanimously in 2024?
Oh, and last thing, there is no mandated funding in here.
Thank you, Senator.
Thank you.
It's nice to see you as the first bill of the year. Next, we're going to have Senate Bill 213. Is the department here for Senate Bill 213? Thank you.
Great. Good morning, Chair Bridle, Vice Chair Hayes, members of the committee. The Health Services Cost Review, I'm John Crom, Executive Director of the Health Services Cost Review Commission, and we appreciate the opportunity to express strong support for Senate Bill 213. Senate Bill 213 ensures continued funding for critical maternal and child health programs in Maryland, only using existing funds, not requesting additional money. In addition, some of the dollars in this fund will be leveraged to draw down additional federal dollars in Medicaid, effectively doubling the resources available for these vital initiatives. Under Maryland's total cost of care model, the state has set some ambitious goals to improve health outcomes related to severe maternal morbidity and childhood asthma. The Maternal and Child Health Improvement Fund, established by the legislature in 2021, through the Budget Reconciliation and Financing Act, provides essential seed funding to create and expand programs designed to meet these goals. So the HSCRC approved a set of programs led by Medicaid and the Prevention and Health Promotion Administration within the Maryland Department of Health when that fund was established. I'll leave the description of the programs to my colleague from the department, Laura Goodman, but these programs were specifically selected for their alignment with the state's maternal and child health goals under the total cost of care model. The dedicated funds approved by the commission can't be diverted to other programs or uses. To date, the HSCRC has allocated $40 million to support maternal and child health interventions led by Medicaid. This funding and the department writ large, the funding was collected through a broad-based hospital assessment, The Maternal and Child Health Fund is currently set to sunset on December 31st, 2025. This bill just proposes to change the sunset provision to sustain and expand these essential programs, enabling MDH to utilize the fund's balance through December 31st, 2027. The HSCRC projects a remaining fund balance of $24.1 million at the end of fiscal year 2025, with less funding available in the account by the current sunset date of December 31st, 2025. So we're confident that these programs are on track for sustainability. To date, MDH has implemented regulations, established contracts, recruited a workforce, and stood up programs. Again, I'll let Laura describe those. But standing up these programs in 2022 and early 2023 was particularly challenging given the COVID-19 pandemic. So, that is part of the consideration here as well. If this bill passes, MDH intends to spend the entirety of the remaining fund balance by the end of 2027. So these programs are essential in reducing health disparities and improving outcomes for Maryland's mothers, children, and families. Extending the sunset provision for 2 additional years allows MDH to scale and sustain these efforts. So we really urge respectfully a favorable report.
Great. Thank you very much. Good morning, Chair Beidel, Vice Chair Hayes, and members of the committee. As Executive Director Crom said, my name is Laura Goodman. I'm Deputy Director of the Medicaid Office of Innovation, Research, and Development. And on behalf of the Maryland Department of Health, I'm excited to be here today in strong support of Senate Bill 213. So the Maternal and Child Health Population Health Improvement Fund supports the state share of several key priority programs under the Medicaid state plan that brings needed services to Maryland families. Additionally, the fund supports programming under the department's Public Health Services Administration. And together, Medicaid and Public Health have dedicated this funding to improving access to quality prenatal and postpartum care services, as well as to improve infant and early child health. So, and these interventions were selected with their potential for impacting improvements in health disparities. And they also align both programs with the total cost of care model as well as the AHEAD model, in addition to the department's Women's Health Action Plan. And additionally, they serve to support the Priority 8 of the governor's state plan, which is ensuring access to world-class health systems for all Marylanders. So with the extension of this funding, as proposed by the bill, it is needed to continue these programs for another 2 years, particularly for the Medicaid program. As Director Crom said, this effectively can double our resources by being able to draw down federal matching dollars. And in the absence of the extension of the funding, state general funds would need to be identified to continue these programs in the Medicaid side and to draw down those federal matching dollars. To date, thousands of Marylanders have accessed these services and benefited from them, and our projections are showing an increased uptake in utilization to allow us to continue to spend out these funds over the next 2 years. And preliminary evaluations of the programs have showed improvements in areas such as severe maternal morbidity, low birth weight, admissions to the neonatal intensive care unit, as well as birth complications. So I'm happy to go into more detail about the programs if that's of interest to the committee. And overall, thank you for your consideration and favorable report.
So, Laura, thank you for your presentation. I would like a list of the programs. I have found, as I've talked to some of the MCOs, they don't even know that they have these programs available. I came to the legislature 18 years ago, and we were talking about maternal health and morbidity, and we're still talking about it 18 years later.
Yes.
So, and we haven't improved. Mm-hmm. So I really would like to see the programs. I'd like to know your plan for how you're reaching out to the populations that need these programs, because I just don't think they know about what's available. Like home visits and, being able to record blood pressures at home. And so I really would like more detail about that. Do I have any other questions from the committee? I can't. Oh, Senator Ellis, thank you. Couldn't see it.
Yeah, no problem, Madam Chair. Thank you. Good morning. It's maybe because I moved while you missed my life.
You move closer to the leadership. That's great.
Yeah, thank you, Madam Chair, and thank you for presentation. And so it's good to see that part of the drawdown of these funds is for some of these programs, that especially we passed, like doula services, stuff like for reimbursement, Medicaid. So thank you for that. I just want to say that, it's very important that, following up on Madam Chair's comments, outreach to the communities, because still in Maryland, the most impacted when it comes to maternal health are African-American moms. They're still 3 times more likely for adverse outcomes through the entire birthing process, pre and post. And we really need to really double down on that. And it's mentioned also there are things that we can do as far as, blood pressure monitoring. There's a bill coming with that. And so I just wanted to ask you, as far as this fund, I think you mentioned 2 years. Will the fund be replenished when these monies, I think so 40 million is used up, and what are the plans to replenish those funds going forward? So that's my question. What are the plans to replenish those funds
Sure.
and when this goes through?
Other questions? Do you have a response, or
no,
can
no.
I dive in?
I can start, and then
Sure.
you can dive in. So,
No, that's my question.
yes.
You're asking for other questions?
No. On this question, so this particular fund, funded through the HSCRC, will not be replenished, so this will sunset. But I'll let Laura speak to the programs.
Absolutely. So in agreement there. In terms of the programs, on the Medicaid side, we selected, 5 programs. So the first is home visiting services. We previously had a pilot, which we were able to expand statewide with the support of this funding. We currently have approved 2 evidence-based programs, Nurse Family Partnership and Healthy Families America. And we are now implementing that with Medicaid funding, I believe 16 programs in 14 Maryland jurisdictions. And we set this program up to mirror its implementation with already existing more grant-funded programs that are implemented by the department's public health side. So that is enabling those grant-funded programs to expand their reach beyond the Medicaid population by bringing in those kind of mutually reinforcing funds. And we're starting to see, and to your point, Chair Beidel, these are difficult metrics to drive. We're starting to see, and our evaluation, is currently from just the 1.5 second year, 18 months of implementation. Some improvements with this population in compliance with later term postpartum visits, and as our population continues to grow and we continue those evaluation activities, I'm hoping that we have a more statistical power, if you will, to be able to have better outcomes descriptions there. So among the doula populations, and thank you, Senator Ellis, for your continued support of that, we were able to launch Medicaid reimbursement of a doula program, which officially went live in February of 2022. And we have been working both within the state as well as working with other states. There's a lot of attention on this across the country to build up a Medicaid doula program that meets the rigor that's needed from our state and federal standards for program and provider integrity, but also launching into the doula side, which are non-traditional providers, many times from the community, as is the model that we would like to continue to promote. And that's challenging because the process of becoming a Medicaid provider, learning to bill, networking with a managed care organization, the health plans, that's all very new to many of these providers who provide such a vital service to their neighbors. So we have taken some as we're working on increasing our doula network and kind of getting more doulas who are embedded with their communities, we've taken some administrative flexibilities. We have lowered the standard for new doula organizations. We've taken it from 9 original organizations that were able to credential eligible doulas, and we now have 30. We are allowing for single contracts with individual MCOs so that and allowing them to be out of network for a few years until we kind of get those processes up. So there's that networking, that contracting barrier is removed until the benefit is fully stood up. And we also more than doubled the labor and delivery rates for the doulas when we saw that our initial rates were not quite competitive anymore from when they were initially set forth. And that's also with the support of the Maternal Child Health Fund. For centering pregnancy, that is our third benefit under the Medicaid program. Centering pregnancy is a group-based prenatal care program that instead of kind of having an individual go into their 9 months of prenatal care, the centering program has group-based, so they have their normal weigh-ins, blood pressure checks, but then they are arranged with a cohort of people around the same gestational age, and they're going through together, learning about pregnancy, learning about what to expect, talking about the stressors. And that was an existing program. What we did there was to add an additional billable code for Medicaid that gives an additional amount of reimbursement for to kind of incentivize and also reward and support practices, obstetric practices to implement this model, which is really promising. And Centering Pregnancy is one of the programs that we're funding on the public health side with these dollars as well to help stand up new sites. So with the support of the fund, we've increased and supported up to 8 Centering Pregnancy sites in the state. And that has shown with the doulas in our kind of small population that we've been able to evaluate so far, those who have used doula services have had 0 instances of severe maternal morbidity, neonatal ICU admissions, or birth complications, which we're excited to continue to monitor that. Under Centering Pregnancy, those individuals have had the 0 instances of neonatal intensive care unit stays, as well as birth complications. Healthy Steps is the fourth. That is it is actually a pediatric model that screens all children 0 to 3 for risk factors and then pairs them with a Healthy Steps specialist in pediatric practice for those who are screened into the higher tiers. And it really helps to improve early detection and intervention of pediatric mental health conditions and family-centric and family-centered treatment. So we have it's similar to Centering Pregnancy. We provide an enhanced reimbursement rate for pediatric practices that implement that model. And we've received recognition from some of the national bodies, such as I believe it's at the Vanderbilt University Prenatal to 3 Policy Institute. So we're starting to gain some traction there. The MOM program is the 5th program that we are using these funds for. That is an enhanced case management program for individuals who are in Medicaid, are pregnant and then postpartum, who have an opioid use disorder. So this came originally out of a CMMI demonstration that was required to take on sustainability at the state level. We were able to do that here in Maryland. And to date, we've grown to over 100, I think we're about 115 individuals who have benefited from this so far. We're excited to continue to grow that. And essentially the case managers, conduct screenings with individuals for social determinants of health, anxiety, depression, and of course continued use of not just opioids, but also other substances. We're seeing really promising results coming out of that, both very few admissions to the neonatal ICU, which of course with this population is expected. Many babies, even if moms are using MOUD for substance use treatments, their infants are still expected to be born with neonatal abstinence syndrome. And the idea is to generate cost savings as well as well-being by shortening or really kind of decreasing those lengths of stay. So that also goes in support of the total cost of care model and our goals there. In addition, in the MOM program, there's the externalities of enhanced kind of life supports. We've seen participants finishing high school, getting their GED, learning to drive, getting their driver's license, securing stable housing.
Okay, thank you
Yes,
so much.
that was it,
Quick-
actually.
Quick question for you. You mentioned also 14 jurisdictions
Yes.
that, could you get that list to us, two list
Yes.
jurisdictions?
Yep.
Okay, thank you so much.
Okay, I'll get that to you.
And thank you,
I have
Madam
it.
Chair.
Thank you, Senator. And then you also asked about outreach, so if you could include in your memo the outreach, I'd appreciate it.
Absolutely.
Thank you. Do I have any other questions? I don't see any other questions for this. That ends the bill hearing for Senate Bill 213. Thank you. John, you can stay there for Senate Bill 229.
Great.
It's the user fee assessment, repeal of the sunset.
Thank you. Continued good morning to the committee. I'm also here to testify in strong support of Senate Bill 229 on behalf of the Health Services Cost Review Commission. This legislation is critical to sustaining the commission's ability to meet its growing responsibilities, support Maryland's unique healthcare transformation efforts, and ensure high-value healthcare for all Marylanders. A bit of background on the user fee assessment. We are an independent state agency responsible for regulating the cost and quality of hospital services under the Maryland Health Model. Our work ensures transparency, promotes equity, and controls healthcare costs to benefit all Marylanders. The commission is funded entirely through user fee assessments on hospitals, which are capped at 0.1% of the prior fiscal year's regulated hospital revenue. So these funds cover our operational costs, primarily staffing, contractors, and overhead. Senate Bill 229 removes the sunset on this funding formula, which has been in place since 2022, and ensures that HSCRC can continue its essential work without interruption. We're not requesting a change to the percentage, and it's important to note that the law requires that HSCRC only collects what's needed to cover actual expenses. When less is needed, we reduce assessments as we did from FY 2024 to FY 2025. And also important to note that we'd still be subject to all of the budget and procurement oversight that state agencies receive. So why is this change necessary? Well, since 2019, under the total cost of care model, HSCRC has taken on considerable new responsibilities, initially focused strictly on the blocking and tackling of hospital rate regulation. HSCRC now supports a number of additional affordability, quality, and population health programs and analyses for the state. We also have significant work on the near horizon at the request of hospitals and other stakeholders, as well as our commissioners, as well as other stakeholders from across the state. We're undertaking significant policy development efforts to ensure that our core financial policies are accounting for access needs across the state and the increasing complexity of our healthcare financing landscape. These are not analyses and policies that we can kind of pull off the shelf. This will require Maryland to yet again lead the charge among states on healthcare affordability and access policy and analytics. Additionally, in recent years, the General Assembly has directed HSCRC to address several pressing issues, such as emergency department wait times, medical debt, trauma funding, and hospital facility fees. These responsibilities we're finding are requiring additional resources, staff, and analytic capacity in order to achieve. Finally, with the upcoming, that's all before we get to the upcoming AHEAD model. Under that model, Maryland will expand its healthcare transformation to increase our focus on population health and reducing disparities, and HSCRC is going to be a central analytic partner for those efforts. We're coming soon to provide a briefing on the AHEAD model, I believe next week. So if the current funding formula sunsets, HSCRC's operating budget will be capped at $20 million in FY 2026, and that's well below the amount included in our budget this year. So we would really start to hit in FY 26 immediately a funding shortfall. So the impact of this user fee on hospitals is fairly small. It's a pretty small proportion of hospital budgets. And again, the funding formula allows us to adjust downward when feasible. The predictable and modest user fee cap ensures financial stability for hospitals, so it's predictable for them while providing HSCRC with the resources that we need. For our agency's long-term sustainability, removing the sunset aligns user fee assessments with the growth rate of the hospital industry, ensuring that our funding keeps pace with inflation and the increasing demands, as I suggested, of our work. Given the work that is required of us, we will, as any agency or healthcare organization must, we'll need to identify cost efficiencies to manage our budget in the future. We have to do more with approximately the same amount of money. But HSCRC requires a consistent budget formula that remains stable over time to ensure predictable funding for essential services, allowing us to do better planning, efficient resource allocation, hiring, et cetera. With a predictable budget, agencies can make better informed decisions about staffing, infrastructure investments, and future program development. Without this adjustment, HSCRC's ability to fulfill its mission and implement the AHEAD model and other statutory requirements would be compromised, putting Maryland's healthcare transformation work at risk. So in closing, Senate Bill 229 is vital to ensuring the continued success of Maryland's healthcare transformation under the total cost of care and AHEAD models. HSCRC's ability to regulate, innovate, and address key healthcare challenges depends on adequate, predictable funding. Without this legislation, Maryland risks undermining the progress that we've made in controlling costs, improving care quality, and advancing health equity. So I respectfully urge the committee to give Senate Bill 229 a favorable report. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you, John. I see a question from Senator Lamb.
Thank you, Madam Chair. A few questions for you. I think you had brought up the AHEAD model, which is obviously still kind of in the works. And, just from a lot of conversations that I've had, it sounds like many of the AHEAD stakeholders haven't had, including the General Assembly and us, didn't have much time to see what the state was agreeing to prior to it being signed with the feds. So stakeholders like hospitals are still trying to figure out what exactly is going to be coming out and expected of them, including the cost implications of AHEAD. So why, while these stakeholders are still trying to figure out AHEAD, does the state need to take this step now to more permanently lock in this funding mechanism for the HSCRC?
Yeah, so great question. So again, we will be coming to brief on the AHEAD in total. I think there are some really critical reasons that we had to make sure that we were signing the state agreement and moving forward in order to preserve some of the really key aspects of the AHEAD model, including, retaining $1.7 billion in federal funding, right?
I get that, but why this bill?
So this bill, though, what's key here is that this is even before we get to any additional work that we would have to do for the AHEAD model. So, for example, we maintain hospital rate setting. We have a number of policies in place, right? That we are actually, we just put out a proposal for comment, a request for comment on a number of our core financial policies. That maintaining those policies is going to be a heavy lift, right? And so this is locking in and stabilizing the funding required to do our kind of regular day-to-day regulatory work.
So I guess the second question stemmed from that. Last year, in the prior session, the General Assembly passed legislation to study all of the MDH commissions, including the HSCRC, MHCC, MCRC, and that study will be back next year. It should include recommendations on how these, if there's any realignment that's recommended for these MDH commissions, that's all going to be looked at. would you be open to, trying to figure out some type of stopgag language in this bill to be able to look at a more permanent funding solution in the broader picture of how all of these commissions could be realigned?
So I think the real challenge is that any agency without kind of stable funding mechanisms, right? Budgets can be adjusted, et cetera. But we're going to have some real challenges hiring and contracting in order to just do the analytic work. I think reorganization could certainly result in different, funding opportunities. If we have more responsibilities, less responsibilities, that, could be looked at in future years. But I think particularly as we look at kind of our current workload, right? If we think about the last couple years when we were coming up to this sunset deadline, we weren't able to hire staff, critical staff that were necessary to do critical work because we couldn't obligate beyond the sunset date, right? So I think we do need to have long-term sustainability, even if there are kind of decisions that have to be made about future workload.
So I guess just to follow up on that. One, that's, I guess, how most other state agencies work, right? I mean, you get a budget for every year. I understand you're trying to do some outlook, planning in futures and whatnot, get that. Although every department and agency generally is looking at a one-year budget coming up. Point one. Point two, the commission's written testimony here notes that we need to pass this bill, otherwise the commission will be significantly underfunded. That's the point that you're trying to make. But instead of having to, we don't actually have to pass this repeal language for this bill. Why can't we just let the sunset lapse, right? Just extend this current provision to allow the fees to continue. Just extend that instead of completely removing the sunset. Looking at it from the other direction.
So if the sunset then would result in a reduced amount of funding.
We'd repeal the sunset, but just extend the period by which this user fee will continue to allow us to have a relook again once the report comes back, once a head is a little bit more settled, to extend this fee for another 2 years, just throwing that number out there, to let us have a better picture of the whole. Let us have a look at it in the bigger picture of things once those have come back ahead. You mentioned the, or I guess I mentioned the report that's being looked at to realign all these commissions and whatnot. Would you be open to that?
I think 2 years is a really challenging time frame, right? I mean, because I think that very short amount of time and kind of not being certain of the funding mechanism, right, is gonna require us to really put a hold on a lot of these things that are pretty critical, like even within the next 2 years, right? So, I think that given the pace of the policy work that we need to do, even within these next 2 years, is going to require a longer time horizon than 2 years of funding stability. So I'm happy to talk through kind of the puts and the takes of the contracts that we would have to kind of let in order to do this work. But I don't realistically see a change to that, even with decisions regarding the AHEAD model.
Well, 2 years is a lot of time. We could be in a very different place with AHEAD in 2 years from now, right? With things kicking into place and everything kind of moving along. 2 years, from a budgeting perspective, it's a year than most departments get. I guess the last question here, I'm just looking at MHA, the Maryland Hospital Administration, or Maryland Hospital Association's testimony. They've put it in as a support with amendments. But, when you read this, it says, however, more time and information is needed before determining whether it is appropriate to remove this sunset. For these reasons, we request a favorable with amendments on this report. When you look at the bill, all the bill is doing is removing, 3 or 4 lines from the statute favorable with amendment sounds like opposed to me from MHA.
So sorry, favorable with amendments sounds like,
Sounds like they're opposed to how this is currently drafted.
so
The draft, the bill just removes 4 lines from the statute, right? And so, I'm trying to understand, if there's a way forward that would be amenable to MHA, for example, by just extending that sunset for a few years, because that seems to be a concern they're bringing up here in their testimony. They're saying support with amendments, but honestly, what are you going to amend when it's just removing 4 lines from the statute, right?
So I'm happy to talk to MHA. I have not spoken with them about
Okay.
about this
Would
bill.
suggest you look at their,
I'm happy to. We
Okay.
did not receive it in advance, but I will say that what we're looking to do here is get to the place where most agencies are, where you have a predictable kind of funding mechanism. The budgetary process, yes, that's year over year, but there has to be some predictability in order for us to make basic hiring and contracting decisions in order to sustain our work, right?
I get that. I guess I just would be more comfortable with just an extension of the sunset rather than just completely removing everything. And I think reading what MHA has put in here, it sounds like they would be too.
I understand that. I think that, I think what we're looking for here, though, is something that, we are going to need a longer term sustainability pathway here. I'm happy to discuss with you and with the MHA what that might look like. But I think over the long run, we got to get to a place that other agencies are in terms of having, the funding mechanism assured.
Right.
So happy to have
Okay.
more discussion.
Yeah, I mean, I totally get the long run picture. I just want to have it in the broader picture of ahead, the realignments that might be coming out of this commission report, or this report that's coming back to us, and all of that. And then we can also just talk about the longer term, kind of sustainability of the commission too.
Happy to do that.
Okay.
Senator, thank you. We have another question from Senator Reedy.
Thank you, Madam Chair, and thank you, Jonathan. I guess at this point, my question is probably echoing what's just been said, but the desire for flexibility and the need to be strategic long-term makes sense to me. I guess I'm a little surprised. I was just looking at the Hospital Association letter and was going to ask you about their thoughts, and you've commented on that already. I guess I'm a little surprised this wouldn't have been a conversation before the bill was introduced, or, I mean, can you speak to that, or?
Yeah, I think we did have initial conversations. We didn't get concerns back. I think these concerns were just emerging, so we'll talk to them more.
Well, I guess, again, because we also know some of us have been here maybe a lot longer than I realized as I look back. I mean, we remember that, and I know that's not the goal of this bill, but we remember that there were times that money was, they raised assessments and then took money into the general fund. So there's been issues about how this mechanism works. So I mean, I think of maybe a longer sunset with more time would be better. But yeah, we'd like, I'm sure the committee, we probably would all like to see what conversations could be had before we move forward. But I appreciate your answers. So thank you.
Thank you, Senator. Do I see any other questions? I do not. Thank you very much.
Thank you.
I think we're done grilling. Thank you, John, for being here.
Thank you.
That ends the hearing on Senate Bill 229, and now we will bring up Senator Washington, Senate Bill 163, which looks like a nice, easy bill, Senator.
Be careful sometimes, I think. So, yes, I think it's very straightforward. Some might say, what's the difference in the name, and we're changing these things, and I'm sure that after being bullied or somebody calling your name, somebody would say, sticks and stones will break my bones, but words will never hurt. And that saying is traced back to 1830, and the idea is like to make you stronger. But the truth of the matter is that while physical wounds heal, the words and the healing for words that are said remain, and it's false to believe that they don't harm. Good afternoon, Chair Beidle, Vice Chair Hayes, and the committee. For the record, I'm Senator Mary Washington. Language is how we see the world. SB 163 is an effort to modernize our health code. And while it was once well-intentioned and a progressive concept to talk about mental hygiene, historically, mental hygiene has arose out of a movement to improve conditions in asylums and advocates for mental wellness. But for many today, mental hygiene evokes stigma and even derogatory notions. Disability Rights Maryland and other advocates have highlighted the damage these outdated terms can cause. This bill proposes a straightforward solution: replace mental hygiene with mental health. The Alliance for Mental Health, NAMI, and the Mental Health Association of Maryland and other advocates stress that mental health and behavioral health not be conflated, that often behavioral health is associated with substance use disorders, creating confusion in how services are provided. In closing, SB 163 is about more than words. It's about dignity, it's about clarity, and it's about creating a Maryland that meets the needs of its people. Thank you for your time and attention. I respectfully request a favorable report on SB 163, and I'll have to note that I removed about 3 paragraphs of this testimony. So now I'd like to invite Michael Gray, Deputy Director of NAMI, to provide his testimony. Thank you, Madam Chair.
Thank you, Senator Washington, and thank you, Madam Chair, Mr. Vice Chair, members of the committee. Thanks for hearing this bill today. Thank you, Senator Washington, for following this very important bill. I am Michael Gray. I'm Deputy Director of NAMI Maryland. NAMI is the National Alliance on Mental Illness. We represent over 58,000 individuals and families impacted by mental health conditions. So that's people living with mental health conditions as well as the families who support them and their communities around the state. As the Senator said, words matter. Words matter. I have a 5-year-old daughter. She's in kindergarten. She's learning a lot of new words. Some words I wish she wouldn't repeat. And I have to explain to her that there are some words that kids can't say. And then there are some words that no one should say. Even more complex and nuanced for a 5-year-old to understand, or for any of us to understand, is that there are terms and phrases that can be just as bad as a bad word. Nothing wrong with the word hygiene. Nothing wrong with the word mental. Putting them together, as Senator Washington pointed out, is problematic. It's harmful to people living with mental health conditions. These people already deal with stigma. They live under this oppressing stigma, discriminatory situation they live in, just trying to access mental health services and live the lives they deserve to live. The word hygiene has a connotation. It means something to do with cleanliness. If you say someone has a hygiene problem, it implies they're dirty. They're unclean. And that's nothing to do with providing mental health services. That's the last thing we want to imply with people who are already, again, facing stigma and oppression as they try to access services and housing, other supports. So whatever exacerbates that stigma is a bad thing. And the right thing to do is make these very simple changes in the language of Maryland law. So NAMI Maryland, again, thanks you for hearing this bill and urges a favorable report. Thank you so much.
Thank you. Do I have any questions? I'm trying to check, Madam Senator, your effective date of this bill.
Yes. I understand that the department has asked for an extension, but there are 9 instances in code where this occurs. Last year, we did a similar change in state code. There was no request for additional funds, nor was there any request for an extension, and also the fiscal note notes the same. So respectfully, I believe they have time to make
So 9 instances, and they thought they needed $93,000 to
Yes,
implement
sir.
the change.
I mean, yes, ma'am, yes.
Oh, it's the regulations, and the regulations.
Well, it's search and replace, so it's,
We will certainly support it. We'll have to look closely at the date, but thank you. Thank
no
you for your
problem.
testimony. Oh, Senator?
bit of trivia, but what wasn't, the Department of Health was previously named the Department of Health and Mental Hygiene.
Yes.
Right.
Yes, and it was changed.
And that was changed.
Yes, it was. As the Johns Hopkins School of Public Health and Hygiene, because of its associations with eugenics. Again, hygiene has a really strong and negative connotation. But again, if the committee, I'm good with, if the committee wants to look at the effective date, maybe we can change the code, the 9 instances, and provide additional time for the regulation. Would again assert the regulation is actually how they operate, so maybe it could be 6 months extra, but it's our understanding it does not take, a whole year and a $90,000 salary to do it. Thank you so much.
The fiscal note writers say they can do it with existing resources, so that's not the
yes,
problem.
right, it's
But
the
thank
time.
you. Thank you for your
Appreciate
testimony
it.
very much.
Thank you so much.
Thank you. If there are no other questions or issues before the committee, this ends our bill hearing today. We'll be back at 1 o'clock for briefing. I was nice and gave you time for lunch.
Hey, look at that.
Thank you.